We're good. I like when we're good. Let's go. Okay, everybody. This is the joy of technology. It's a joy and a curse, isn't it? So some of you will have come across Arundhati Roy's beautiful essay where she says pandemics force us to break with the past and think about the world anew. And this is no different. COVID-19 is no different. It's a portal. And a portal is a gateway between one world and the next. And I guess what she's saying in this quote is we can choose to walk through it with all our current baggage, or we can step through into another world with very little luggage, ready to imagine another world and be ready to fight for it. So this is the theme of my presentation today, is I'm inviting nurses who already are carrying far too much to maybe walk lightly with me to imagine other futures. That's the theme of my presentation. But let me start by telling you a little bit about me. This is me and my family when we arrived in Aotearoa in the 70s, and you can see us there on the day of our citizenship ceremony. I did my nursing at AUT. That was in the days of the mullet. You can see my cool mullet hair there, short at the back, long at the top. I'd also had a perm, so it was pretty cool. And this is near where Princess Mary Hospital used to be. So I was on my way to do a shift there, an afternoon shift with my friend Rosemary. And we used to have a bit of a laugh in the clinical practice rooms there, which pretty much look the same now. And I started out my career working in mental health. I worked at Carrington Hospital. I worked at 393 Drug Clinic. And then I also worked in maternity and set up a maternal mental health team. Did my PhD, did a lot of work teaching kaimahi, kaiawhina, Māori and Pasifika support workers, and completed my PhD in 2011. And at that point, applied for work in Australia. I was looking for some new opportunities to make the most of my PhD. And what I've been doing here is work around how might we implement cultural safety? How do we do community health in multicultural populations? And what do data, digital and design, what can we do with those to make them responsive and culturally safe? I'm also a fellow of the College of Australian Nurses. So I'm kind of keen to talk to you about the future. And I've been thinking about what the future might look like. I know a lot of you will have been as well. And I'm just going to rustle my papers so I get on my right page here. And I guess what I want to say is, oh, don't play with your mouse. That's what I want to say. And sorry about this. Okay, here we go. I'll keep my mouse away from me. So I want you to imagine that it's 2030 and this is where I'm talking to you from. And I'm 65, but I've had a bit of Botox, so I look a lot younger. So one of the futures that I have is that I can't retire. Housing's become very expensive, especially in Australia where I live. Everyone has moved to higher ground away from hazards such as rising seas and fire risks. Robots now do care work. Algorithms manage the distribution of services. The government has withdrawn from its role in providing universal care and justice. Nurses are only available for the very wealthy and the resourced. For some, it's meant branching out into caring for rich people's pets. It's all about the survival of the fittest and the wealthiest. The recipients of care work are the elite who can pay for it. My second future, I've retired. I tend to a permaculture shared plot of land that provides adequately for all who live in this intergenerational community, where knowledge and skills are shared. Different kinds of labour constitute a contribution to the community, which means that everyone gets taken care of. Mutual care flourishes, everyone thrives. There's a focus on equity, generosity, and flourishing. We've moved away from scarcity thinking. I work when I feel like it. Usually it's offering clinical supervision or career coaching in return for a good chat about where nursing is at these days. The health system has become highly sophisticated. Technology enables clinicians and support staff to focus on care. There's a recognition of the physical and emotional demands that caring takes up, so that people working in health all have 3 days off a week, so they've got time to recover from the demands of the field. Evidence-based care is embedded in care, and other forms of knowledge, for example, spiritual and cultural, are given space and respect. So one of the things that happened during COVID is that 2020, as you know, was both the year of the nurse and the year of the pandemic. The nurses hoped that we could elevate the status of nursing, but those hopes were raised and then dashed in ways that none of us expected. The general public came to realize how indispensable nurses and nursing was. There was cheering in the streets because nurses were seen as heroes and angels. Who else could be so exceptional in a pandemic? Contact tracers, triages, ICU and community care, vaccinators at the ready, but also innovators who helped family members connect with sick family or grieving people through technology. Even at their own risk, without adequate staffing or PPE, nurses pushed on. The pandemic exposed workforce gaps. In Australia, there were tragic losses of life in aged care where profit makers exploited workers from racialised communities. Some people worked in multiple facilities spreading the virus, and there was a shortage of registered nurses. Nurses, however, still did not have a voice at the policy decision-making table. In Australia, nurses were excluded from vaccination strategy discussions. The problem with this dialogue about angel or hero, though, was it meant that nurses were recognised for their courage and self-sacrifice, but it undermined the professionalism and skills of nurses because it reinforced the public's view that nursing was an innately feminine nurturing role rather than one that requires skill, education, knowledge, and discipline. So COVID-19 made us reimagine justice and equity. And I'm not sure if many people can recognize this place, but it's one of my favorite spots. This is Aotearoa, where I've spent many years camping on whānau land. Big shout out to my Ngāti Porou friends. Iwi here set up coronavirus roadblocks. They asserted tino rangatiratanga and sovereignty. Let me tell you some of the other amazing things that happened during COVID. We reimagined care and justice. We started valuing care work. We made sure everyone could advance. We ensured there was pay equity. We ensured there was reproductive support for all genders. We were ready for climate changes and we were ready to respond to emergencies. Everyone had a universal basic income. In Australia, we called it JobKeeper. We realised that there were inequitable impacts of the pandemic. We also realised that the most innovative responses were led by First Nations, Pasifika, and ethnic communities. We started collaborating more and sharing. We supported each other. Technology became accessible and affordable. All the things that we thought we couldn't do happened. We zoomed, like I do on this boogie board. We zoomed into all kinds of meetings, all kinds of consultations in ways we'd never imagined. So the world of health became changed by the world. We started thinking about resourcing health services so that resources and personnel were sustainable. People did not have to be overworked because working conditions and social practices meant that people had leisure time and didn't have to do a second or a third shift. We developed innovative practices. Nurses had always had great ideas and were responsive to the world of practice. This meant that new ideas could be implemented and evaluated quickly. Technology was designed around practice rather than the other way around. Care was person, family, and whānau-centred. Health systems partnered with communities who they'd previously described as hard to reach. They saw how effectively communities had rallied to provide culturally responsive health messaging and engagement during the pandemic. And here's a photo of that time where the Tongan community had a drive-in for COVID vaccinations. People understood that a rising tide lifts all boats, that unless the most marginalised was supported and healthy, no one else could be healthy. So this changed how we thought about nursing. We started thinking about hope as a discipline. One of my idols, Mariam Kaba, says that hope doesn't preclude feeling sad or frustrated or angry. Hope isn't just an emotion. It's not just optimism. Hope is a discipline. It's a commitment to the future that must manifest as action. Hope is a discipline that matters most when it is hardest and when the stakes are highest. This is a time where we need hope. It's not that idea that everything's going to be fine and we can just sit back, or pessimism, which is that everything's going to suck and we can just sit back. Hope means a sense of uncertainty, of coming to terms with the fact that we don't know what will happen next. But maybe there's room to intervene, a choice to do what we can in this moment to bring about a change, no matter how small in the next. So I'm going to share with you some people who've done amazing work between 2020 and 2030. And these are some of the features of the work that they do. They've had fearless speech, parrhesia. They've spoken out. They've developed partnerships. They work in interdisciplinary ways. They've built alliances and networks. They vision futures. They challenge inequity. And they see challenges as intersectional. Here's someone you might know. There's Kerry Nuku. And I just want to acknowledge this amazing award that you've received. And I want to introduce you to someone else from Australia. This is a friend of mine, Janine Mohammed, who's from a Ghana woman from South Australia. She was CEO of Katsanam, and she's now CEO of the Luicha Institute. Her work is an example of how cultural safety became part of our code of conduct in Australia. Without her work, joining up all the national nursing organisations, it wouldn't be part of our code of conduct. And I know that Kerry's done some work internationally connecting a whole lot of Indigenous interests. Here's Monica McElmore. She says, if we centre the most marginalised people, care improves for everyone. Her work combines nursing, public health and policy research, and she translates her work. I'm going to speed up now because I don't want to make you late. So I'm going to skim through these. Some of you might know Mikey. I beg your pardon? Oh, okay. Okay. Then we've got Mikey Brendorfer. Some of you might know Mikey. I'll let you read that and I'll have a sip of my tea. I hope you're sipping a nice cup of tea or coffee at the same time. I love Mikey's work. They're someone I met when they were my student at AUT. And at the time, they were making soup, vegan soup for homeless shelters, where we would do health checks with nursing students. They've kept up this commitment to youth health, to the marginalised, and to education. They also work across climate change and transgender health. And they use social media to advocate against ableism. Now, this is terrible trying to pick out all these people because I know there are lots of people that do lots of things. But I was thinking about the specific challenges that are facing us coming into the future. In the US, I thought I'd look around the world. We've got Jess Dillard Wright, who's an activist, nurse and midwife, scholar organizer, based in Georgia. And what they've done is build so many alliances. Take a screenshot of this if you're interested in it, because there's some really terrific writing happening, really great critique and challenge. and their work that I'm contributing to. We've got a book coming out about radical futurities for nursing. So Jess is committed to not just visioning, but building a more just, equitable future. Then we've got Sally Thorne, who is the editor-in-chief of Nursing Inquiry, which is one of my favourite journals. And her work consistently, her editorials challenge inequity, racism. She's a voice for others. So her editorials range from talking about racism to also groups affected by stigma, marginality, and criminality, for example, opioid users. And she's committed to health for all, improving equity, compassion, and accountability. Then we've got Rae Walker, who does work in the design justice, consumer engagement, co-design space. And they're an inventor who's developed sensors, wearables, and digital health technologies. Cool things such as computational eyeglasses, microfluidics, radar-based sensing, accelerometers, and nanotechnology. And they were also involved in founding Nursing Mutual Aid, which I mentioned earlier. So this is my concluding slide. And my question to all of you, and maybe your photo goes there where Octavia Butler's face is at the moment. My question is, can we imagine and craft a world that is more livable, more just and joyful for all of Earth's inhabitants? Or will we hang on desperately to the familiar, pining for a return to normality? Octavia Butler said, all that you touch, you change, and all that you touch changes you back. There's no single answer that will solve all of our future problems. There's no magic bullet. Instead, there are thousands of answers at least. You can be one of them if you choose to be. Thank you.
No reira e te iwi. A tēnei te mihi ati kia koe whana Ruth. To that final question from me is koe, ko koe, ko koe, koe. You are me and I am you.
And if we looked at the world a little bit like that, maybe we might be able to get back that picture that you painted for us. And you know, when I was talking to you before in the green room, and we were having a quick little
You. And then you put that picture up of. So I just want to mihi to you again for finding time,
especially at this time of the hour over there in Australia, to come and be with us and to share with the te hunga mā taki ana ki tō rātou kāinga. So those that are watching and have joined our conference today.
Ruth. Now we're going to go to a quick.
To put the question to fire. So we'll just see if there's anything that comes up on the Q&A fire, Ruth.
Oh, I think someone's got their hand up somewhere, no? Have they? No. No hands up.
No, lots of mihi for them.
Oh, thank you.
Oh, here we go.
Don't be shy, people. I know nurses aren't shy. Like, I was looking forward to all the dancing that we'd have in person, because nurses know how to enjoy themselves, because the work can be hard, so they know how to party hard. Sorry about all the technical glitches, folks.
I think we're sort of used to that now, finding out how good things are in regards to Wi-Fi and broadband. Okay. So whānau, nothing's come up in the Q&A. We're just going to check to see if you're going to put any questions in the discussion forum. If not, then we're going to close the session. So we'll give you a minute.
For all the shy people.
Aye. Yeah.
Yeah, am I going to get my virtual morning tea? What's for virtual morning tea?
A waiata whaia, a waiata. We've got our whaia Eseta Whinau. Malo, Dr. Ruth, for that presentation. We'll do a Tongan dance for you, Ruth.
Malo pito for Ilole. I went to high school in Tonga, so I learned how to do the laka laka. You should see me on the dance floor. Whoa.
Well, Whaia Ruth, doesn't look like there's any questions for you this morning. Anō nei taku mihi kia koe. Thank you very, very much for finding the time to come and be with us this morning, this early over there in Australia. Kei te whakaaro nui mātou kia koutou ki tā wahi ki ahi te reiria. Koutou te iwi take take. E noho mai nā ki ahi te reiria. Tēnā koutou. Tēnā koe Whaia. Tēnā koe. Tēnā koe. Oh, Kerry has a question. There are some questions in the box. Kei here. Pātai mai tō pātai, Kerry.
Oh, here we go. I see them all. Look at that. Okay. Shall we start with Suzanne? She says, are you able to talk about how your digital health literacy works for marginalised communities? Great question, Suzanne. I can also put a link to a paper I've written about this, but I think the important thing for me has been working with communities to co-design and to find out their ideas about what kind of digital health literacies are needed. But is there somewhere maybe I can cut and paste a link and put it in the discussion forum, and I'll do that in the tea break for that question. And Kerry, you've got a question. Are you going to do that live? I'm not sure if that's enabled. Kerry, are you there?
All right.
Hello.
Hey.
Hey.
Gosh, kia ora, e hoa. It's lovely to have you, even though it's virtually, Ruth. It was such a privilege when we were over and caught up at the Katsunam, the Congress of Aboriginal and Torres Strait Islanders, and Tracy Morgan and myself took every photo moment to have a picture with you next to that vibrant hair. But I just want to mihi to you and an admiration for the work and the courage that you continue to lead and forge and give us hope. Because I think in a health workforce, or certainly within a health sector, one of the challenges are that sometimes our nurses or healthcare workforce are less than what we would consider knowledgeable, but certainly in terms of how to deal with the cultural issues, how to consider that the words, the language that are spoken or shared have hurt. And at the end of those hurtful arrows, they land on somebody and erode the mana, or as it's intended to do. So I know that over the last few months, there have been considerable increase in the amount of overt racism. And we know that from our colleagues in the States, xenophobia and the less than charitable comments coming from not just members of the public, from the health sector, have been less than helpful. So we kind of think, well, we've got this aspiration around whakaruruhau and the legacy that Iri Hapati Ramsden left us. How does work begin on a healthcare workforce? How do we ensure that clinical competence and cultural safety are given the same weighting? Because it seems to be that we're struggling with that And if we want to look at health equity, if we want to look at and imagine a future where we're free to be Māori and proud to stand as Māori or any other in group of people, how do we do that?
This is the million-dollar question, Kerry. But I think what the pandemic has exposed, and what I was trying to say in my keynote, is that we've got a portal here. For some people, they've never really understood that racism exists. Whereas those who embody a kind of body that has felt those arrows that you're talking about know that it exists. But we've seen it firsthand. We've seen it in the distribution of vaccines. We've seen it in the policing measures in Australia, what are called carceral, punitive policing responses, where people in rich suburbs have been less policed than people in poor suburbs, where lockdowns have happened in housing towers where poor people live with very little notice, with no culturally appropriate communication or resourcing or support. And then we've seen the ways in which these communities have utterly stepped up and outperformed the health system. So the thing that I hope is that we can see it in our faces in a way that we've never been able to see it. So, in Australia, the Black Lives Matter marches, everyone came out. Everyone came out. I've been to so many marches here, and that was by far the biggest one I had ever seen. We were all masked. The Aboriginal and Torres Strait organisers had tons of hand sanitizers, tons of masks for everybody. And, once you've seen it, you can't look away. And so that's my hope with the pandemic. It showed this giant mirror to all of us about who is suffering, who is doing the essential work, who needs to be supported. And I think once we've seen it, we can't unsee it. And I think it's the responsibility of people in power. I mean, I was challenging nurses in my presentation, but I think the more power you have, the more of an obligation you have to do something about inequity, as you say. But here, the kind of racism has been really interesting because I've been doing research about it. So, for example, in the early days when a lot of people of Asian appearance started wearing masks, there was a lot of verbal abuse and being challenged. We also found that our international students, for whom the entire university sector depends upon, were left basically to queue up at food kitchens and soup kitchens because there was no support for them, despite the government relying on this, this group of people to keep universities going. Since the beginning of the pandemic, 70,000 jobs have gone from the university sector in Australia. So, people are feeling it really hard over here. And of course, it varies by state, just as Aucklanders will be struggling at the moment. In Australia, it's been Victoria that's really had the pointy end of a massive number of lockdowns. This is why I have terrible lockdown hair. And I thought I'd wear silver, so at least I looked a little bit cool, But we've got a lot of work to do. But my hope is that the pandemic has exposed where the gaps and where the holes in the system are, so that we have to take notice of them. In Australia, it was in the aged care sector where people were working multiple jobs in multiple facilities. And then we had to say, hang on, if people don't have a living wage, then they have to have multiple jobs. Some of the outbreaks happened in freezing works, where there are a lot of people in very small spaces with very confined and very dense. That's where a significant outbreak happened. So, and in these occupations, in aged care and in freezing works, they're people of colour, and so there's been a lot of conversation and activism around making sure people have a living wage so they don't have to have multiple jobs and risk spreading the, COVID, the virus. So I think we are learning very slowly that we have to take care of people, and particularly the poorest people who are doing the hardest, dirty, dangerous jobs. We have to look after them. Sorry, that was such a long answer.
Very much. And again, really admire the mahi that you're doing, and certainly taking to the surf every chance you can get, it looks like. Thank you.
I sure am. Thank you, Kerry.